Imagine a patient come after road traffic accident with a double vision and flat cheek. So what fracture is this? In next 10 minutes I will make zygomatic fracture super easy for you. So today we will understand its definition, clinical features, classification, surgical management, that is closed and open reduction, fixation, post-operating care, complication. So let's start. So first is the definition of a zygomatic fracture. So zygomatic fractures, it refers to a break in the zygomatic bone, that is, which is also called as cheekbone, commonly known as tripod fracture or the zygomatico-maxillary complex fracture. Okay, so why tripod? Because usually it involves 3 or the 4 sutures area. So according to the diagram which you can see, the fractures typically involve the zygomatic arch, that is this one is a zygomatic arch, zygomatico-maxillary sutures, this one is the zygomatico-maxillary sutures, zygomatico-temporal sutures, so this one is zygomatico-temporal sutures, and this one is zygomatico-frontal sutures. Okay, so here the quick question is, why is this bone important? Because it forms the cheek prominence and the part of the orbit. Okay, so it typically involving the zygomatic arch, zygomatico-maxillary suture, zygomatical temporal suture and the zygomatical frontal suture. Okay, so now imagine a patient in front of you. So what you will see? Flattening of the molar prominence, that is a cheek. The cheeks look depressed. Why? Because the bone is displaced inward. Second one is periorbital ecchymosis and the edema, so swelling and the bruising around the area. Subconjunctival hemorrhage, that is a red eye without posterior limit. So it is very important exam point. So you see here a subconjunctival hemorrhage, C is red eye. Okay, now the fourth one is infraorbital nerve paresthesia, that is a numbness of the upper lip, upper teeth and the cheek. Okay, now so why? Because infraorbital nerve runs here. Okay, now the diplopia is a double vision due to the orbital floor involvement. Trismus, that is a restriction mouth opening. The seventh one is step deformity at the infraorbital rim or the zygomatic arch. Now the last one is epitaxis, that is a bleeding from the nose. Okay, so Viva question is, which nerve is commonly affecting? So your answer will be infraorbital nerve. Now the classifications, first one is according to the Knight and North classification. Group 1 is undisplaced fracture, group 2nd is arch fracture, group 3rd is unrotated body fracture, group 4th is medially rotated body fracture, group 5th is laterally rotated body fracture, and group 6 is complex fracture. So your easy trick will be from simple to complex. Okay, now according to the Rowe and Killey's classification, so type 1 is there is no significant displacement, type 2nd is fracture of the zygomatic arch, type 3rd is rotation around the vertical axis, that it includes the inward displacement of the orbital rim, outward displacement of the orbital rim. Type 4th is rotation around the longitudinal axis, it includes medial displacement of the frontal process and lateral displacement of the frontal process. Type 5th is displacement of the complex, that is medially, inferior and lateral, which is very rare. Now type 6th is displacement of the orbito-antral displacement inferiorly and superiorly. Now type 7th is orbital rib segment displacement. Type 8 is, that is a complex community fracture. So here is a question, so which type is most severe? So your answer will be type 8. Okay, so it is a community type fracture. Okay, now the surgical technique for the zygomatic fracture. So the management depends on the displacement. So there are the two main types, that is a closed reduction and the open reduction and internal fixation. So we will see the indication for the surgery. So you see there is it will needed when displacement of the cosmetic deformity, trismus due to the arch impingement, diplopia or global malposition, infraorbital nerve dysfunction, or you can see due to the involvement of the orbital rim or the floor. So we can need surgery. Okay, so there are the two types of surgery techniques. So first one is closed reduction, that is the internal, and the open reduction and internal fixation. So we will see the internal reduction. So here are the indications. So it is used in isolated zygomatic arch fracture, minimally displaced minimally displacement, that is a zygomatic or maxillary complex fracture, fracture causing the trismus due to the impingement or the coordinate process, and the cosmetic asymmetry from the depressed molar bone. So here are the contraindications. So it is contraindicated in the severely cumulative zygomatic fracture, displaced fractures needing rigid fixation, and zygomatic or complex fractures involving the orbital rim or the floor. Okay. So instrument required for the closed reduction is Gilles elevator, that is a L shape. You see this is a L shape, scalpel which is number 15 blade, and periostal elevator. This one is periostal elevator. So these are the instruments required for the closed reduction. So which elevator is used? So it will be Gilles elevator. Now the surgical techniques. So first one is patient preparation. For patient preparation, we do general anesthesia is preferred. Patient is in supine position and hand turned to the opposite side. The surgical site is shaped and prepared with the antiseptic. Okay. So here are the incisions. So 2 to 2.7 centimeter horizontal incision is made in the temporal region within the hairline, approximately 2 centimeter above the zygoma and anterior to the ear. So you can see a 2 to 2.5 centimeter horizontal incision is made in the temporal region, and it will be given in front anterior to the ear but above the zygoma. Okay. Now the incision is made through skin, subcutaneous tissue, and the temporal fascia. Okay. The dissection. So inside the temporal fascia is inside. Blunt dissection is carried out deep to the fascia, but it is superficial to the temporalis muscle. Okay. So you can see in this diagram, this one is temporalis fascia, this one is temporal fascia, and this one is temporalis muscle. Okay. So you will dissecting between the fascia and the temporalis muscle. Okay. So you should be superficial to the temporalis muscle. So dissected it directly and fairly anterior towards the zygomatic arch, and a glove finger can guide the elevators down to the fracture site. Okay. So the insertion of the elevator. So a Gilles elevator is inserted through the dissected channels between the temporalis muscles and the fascia. So you see this one is Gilles elevator, which is inserted through the dissected canal. So the blade of the elevator is advanced gently until it lies beneath the zygomatic arch. So you see this one is zygomatic arch. So until it lies beneath the zygomatic arch, the blade of the elevator is advanced gently. Okay. So now you see the reduction of the fracture. So once the elevator is properly positioned, controlled upward and outward force is applied to elevate the depressed zygomatic arch or the complex. So you see, once this elevator is positioned properly, this is the beneath the zygomatic arch. So you will applying the outward and the upward force. Okay. So this one is upward force and this one is outward force, and the upward force you will apply. So a distinct click may be felt as the bone returns to the anatomical position. Now the malar prominence is palpate and compared to the contralateral side of the symmetry. So then compare the both cheeks for the symmetry. So here is the important is always compare with the opposite side. Now the next one is closure. For closure, hemostasis is achieved. The temporalis fascia, subcutaneous tissue and skin are closed in layer. Non-absorbable sutures are usually used for the skin. So here are the post-operating care for the closed reduction. Ice pack for the 24 to 48 hours. Analgesics, antibiotics, head elevation, soft diet if trismus are present, and following images are required. Here is the advantages of the closed reduction is minimally invasive, hidden scare in the hairline, and there will be rapid procedure. Okay. Now the open reduction. So this is the indication. So there are the indications of the open reduction. So it is severely displaced zygomatic complex fracture in community fractures, orbital rim or floor involvement, persistent diplopia, infraorbital nerve dysfunction, and in cosmetics deformity, open reduction is needed. In contraindication, so when we avoiding the open reduction, when the medically unfit patient, undisplaced or minimally displaced fracture in pediatric patient with a growing skeleton, okay, with a growing facial skeleton. So this is a technique for the open reduction and internal fixation. So first we will giving the anesthesia and we will perform under the general anesthesia. The face is clean and wrapped in still life fashion. So incision is we giving the first one is lateral eyebrow incision. So a 1.5 to 2 centimeter incision is given over the lateral end of the eyebrow. So it will exposing the frontozygomatic suture. Okay, so this one is lateral eyebrow incision, which is 1.5 to 2 centimeter incision. It will exposing the frontozygomatic suture. Now the next type of incision is subciliary and transcondylar incision. So subciliary is it is assist to the infraorbital rim of the orbital floor. It is just below the eyelash. So this one is subciliary incision. Okay, just below the eyelash. Now the third one is intraoral, that is a keen approach. So it will incision is given in the upper buccal sulcus, that is opposite to the molar. It will exposing the zygomatic buttress. So here the question is which incision give assist to the infraorbital rim. So your answer will be subciliary or the transcondylar. Now the fracture exposed. So first after the incision, the soft tissue is retracted and fracture segments are identified. So you will see this type of incision is a intraoral, that is a keen approach. Periosteum is carefully elevated, bone fragment and mobilized, reduced anatomically using the elevators or reducing forceps. Orbital floor is inspecting and reconstructed if required. So in this second image you see the periosteum is used, is carefully elevated, the bone fragments. So this one is bone fragments, it is carefully elevated. It reducing the anatomically using the elevation or the reduction. Okay. Now the internal fixation. So internal fixation we using the mini plates, that is a 1.5 mm to 2 mm system are fixed using the titanium screw. So here are the common fixation points. So first one is frontozygomatic suture. So what is frontozygomatic? This one is frontozygomatic suture. So you will giving the mini plate here. Now the second one is infraorbital rim, that is the infraorbital rim here. Third one is zygomatico-maxillary buttress. So you see here is a zygomatico-maxillary sutures, you giving the mini plate. And the last one is zygomatic arch, which is really fixed unless community. Okay, so this one is zygomatic arch. So you will giving here mini plate. Okay, so zygomatic arch is very rare until when there will be community fractures involved. So you will giving the zygomatic arch mini plate. Okay. So here is you see the 3-point fixation. So it will be standard. You have to give in the 3-point fixation at least. So that is frontozygomatic, infraorbital rim and zygomatico-maxillary buttress. And 4th point fixation, which is severe case, you giving the 4-point fixation, that is all above plus zygomatic arch. Now the wound closure. Now what we will do? We do irrigation of the wound with saline and antiseptic. Closure in layer, that is mucosal. Intraoral we giving the absorbable sutures, and skin, eyebrow or subciliary we go for the non-absorbable fine suture. Then we go for dressing applied. Sterilite dressing is applied. So post-operating care for the open reduction, antibiotics and analgesics given, cold compress for 24 to 48 hours, elevation of head, soft diet, avoid pressure or trauma to the face, sutures removal if 5 to 7 days if skin is sutures. Okay, so complication we face infection, infraorbital nerve damage, diplopia, that is a persistent scar formation. So here is an important exam question, which is the most common nerve complication, that is the infraorbital nerve is damaged. Okay. So today we learned definition, clinical features, classification, closed reduction, open reduction, fixation point, post-operating care, complication. If this video helpful, like, share and subscribe to Exam 3-Point Dentistry and comment below the closed reduction is done by which technique. See you in the next video. Thank you so much.